speaker is Professor Daud. Professor Daud is the senior most person among us, and if you read his profile, that is at least a page long. And I'm sure, I don't want to waste his time. He's a consultant, retired consultant ophthalmologist, and retired as a vice chancellor of Khyber Medical University. He's the chair of CHEF International, which is Comprehensive Health and Education Forum. He has served as advisor at WHO and SARC level. There is a very long list, so I think that WHO and SARC is enough. So without further ado, I will give this mic to him.
Bismillahir Rahmanir Rahim. One part of the introduction which my dear friend missed is you heard the story of South Waziristan in the morning from Professor Salim. I come from North Waziristan. And I didn't study in HSN. I studied, my schooling was in Miran Shah, which is in North Waziristan. I did metric from there, came to Peshawar, did FEC from Islamic College Peshawar, then Khyber Medical College, did MBBS in 1969, came to UK, spent 6.5 years here, and then went back. And then I was assistant professor, associate professor. I also was administrator of Lady Reading Hospital, like Ghafoor Saab. Then I was chief executive of 2 other hospitals. And then I got retired from there and became founder vice chancellor of Khyber Medical University. And I was president of the Ophthalmological Society of Pakistan twice, president of the Asia Pacific Academy, president of the SARC Academy of Ophthalmology. So, and this afternoon, I'm going to share with you a very interesting story. And the story is about Pakistan. So you will see a lot of things about. I'm going to take you back to Pakistan for a while. So, the World Health Organization said that health is the basic and fundamental right of people, and almost all countries are signatories to that. But despite that, large segments of population remain unserved. Are underserved. The net result is that there is inequitable distribution of health services, unacceptably high rates of disease, disabilities, or deaths, disastrous socioeconomic consequences. Such pathetic situations exist in almost all developing countries in Asia, Africa, and South America. The million-dollar question is, can we reverse this trend, and how? So let's look at the hypothesis. And the hypothesis is that if necessary conditions are genuinely met, successful national healthcare programs can be initiated, implemented, and successfully sustained under the most adverse conditions with strong positive impact on quality of life of millions of men, women, and children. So let's see at this hypothesis if this can be proved right. Let's see at Pakistan National Eye Care Program from 1980 to 2004. Let's go back to Pakistan. A very interesting country. It's in Southeast Asia. You know it, in South Asia, but at the junction of West Asia, Central Asia, and East Asia. The population since morning, you must have been seeing 207 million. Now this is because they are not adding Gilgit and Kashmir to it. So I have added that to it. That's part of Pakistan. And that sees 211.75 million. You can see it's a young population. The age is reaching, average age is reaching 67.7. 40%, it's very interesting. The population is not exponentially increasing, it is also aging. 40% of Pakistani live on less than $2 a day. Now, let's look at the birth trauma of this country. It's a mixture of joys and sorrows. Pakistan wins freedom, but partition caused death, disease, and destruction and displacement of something like 20 million people. And we had to live with that. Let's look at the geographic challenges of the country. On one side is China, on the other side is India. And then this new interesting business of the CPAC, the revival of the Great Silk Route. And then on this side, you see the political instability, the socio-economic chaos, the hot seat of the great game continuum. You've all been seeing how the great game has been played there since 1978. Now, let's look at the challenges that Pakistan is facing, other challenges: rising population, aging population, poverty, illiteracy, regional conflicts, political instability, and reactive activism. Reactivism. Let's look at the aging population. That's what our average age was in 1951, 34 years. Population, sorry, that's where our population, 34 million. And look at it, 211 million. And let's look at aging. 44 years was our average age, and now 67.7 is our average age. So we are not only proliferating horizontally, we are also growing vertically. Then look at the social contrast. On one side, we are caught in this vicious cycle of poverty, deprivation, and extremism. And on the other side, we have illiteracy and disease. But look at this social on this side of the population, and look at this side of the population. So the social scientists can tell you what is going to happen to that country. But don't forget, here is the extremism. With love, and this is what Lord Mountbatten said, with love you can persuade a Pathan to go to hell with you, but by force you cannot take him into heaven. So now let's come back to I. Now imagine this, we inherited at birth, we only had 78 doctors for the entire country, 78. Now, about I, there were two major missionary hospitals, one in Taxla, which was in fact serving the north of Pakistan, and then one in Quetta and Sindh, which was served by Sir Henry Holland, and this was Noel Christie and his wife. By 1950-60, we had some department in public sector. We also had one in Karachi, Multan, Peshawar, and we have the Armed Forces Institute departments of ophthalmology. However, no organized services were available for 80% of population. In 1958, EPAW was born, and in 1960 they had the first session. And Sir Stuart Dew-Calder from the United Kingdom, he was the president of the International Council of Ophthalmology at that time, and he sent this message: I know of no greater stimulus for the progress of ophthalmology in the vast area which EPAW represents than the institution of a body like yours. So, the EPAW people wrote to Pakistan, this gentleman, most of you must be the pupil of this gentleman, Mumtaz Quli Khan from Lahore. So they wrote to him, and the two of them, this gentleman, Lieutenant General Burki, they laid down the foundation of Ophthalmological Society in Pakistan in 1957. Now, General Burki then was at that time the vice president, much later in the Ayub Khan regime. He was the vice president of the country. And very interestingly, this man laid down the foundation of 4 key institutions in Pakistan. And look, what are they? Pakistan Medical and Dental Council, Pakistan Medical Research Council, the College of Physicians and Surgeons of Pakistan, and the Jinnah Postgraduate Institute. All happened in one go. In 1979, the EPAW came to Pakistan, and General Ziaul-Haq was there as a chief guest. He spent a lot of time, and he met a lot of people, and he instituted a medal in the name of Ramzan Ali Sayed, who in fact got that medal on that occasion. World Health Organization was watching the keen interest of the president of the country in disability, and with particular focus to eye. So they sent this gentleman, Professor Hugh Taylor. He's now the current president of the International Council of Ophthalmology. And he gave this wake-up call that the country suffers a prevalence of 2% of blindness, that there are only 80 ophthalmologists to serve 100 million population. There is a gross mismatch of human resource. Cataract is the major cause. 45 out of 64 districts don't have an ophthalmologist. So this was the wake-up call that we received. And here is the gentleman, a very tall, very, very sincere, very pious, and a very brave professor from Karachi. He became the national coordinator, and the president constituted a national committee for eye camp. It's like a firefighting committee in 1985. The first national and 4 provincial coordinators were appointed. A national survey was conducted for the first time in the country in 1987-90. And Ministry of Health notified the first national PBL, Prevention of Blindness Committee. So thus the seed was sown. And in that national survey, which was in fact criticized by a number of international experts, that they did not follow the normal principles of epidemiology. However, we made this as a tool for advocacy. It turned out to be that our blindness prevalence was 1.78%, and cataract was indeed the commonest cause. Now, in 1994, the guards of the National Committee changed, and a new gentleman took over. And by this time, we had the knowledge that if we want to win this battle against blindness, then we have to have these 5-6 things: information and research, financial resources, health, human resource development, infrastructure, technology, and management. And we knew that we will have to do very strong advocacy with the profession as well as with the government. We also knew we will need strong collaborative arrangements, and we knew that what should be our ultimate intervention goals, and that goal would be equitable healthcare in the entire country. And we knew that we have to use the district as a unit, and the service will have to be comprehensive, consisting of preventive, promotive, curative intervention, and rehabilitation, all 4 areas of intervention. Integrated, high quality, sustainable. And we knew that at the end of the day, if we do this, we'll be very proud and say that we have achieved equity and justice in healthcare delivery. So the conceptual framework was that we will do whatever we do, it will be evidence-based. We'll make district as our front line of intervention. It will lead to provincial eye care, provincial comprehensive eye care service, and that will lead to national comprehensive eye care service. We said we will not compromise on 3 things: access, quality, and relevance, and of course these 4: comprehensive, coordinated, sustainable, based on strong collaboration and partnership. Now, research question was, what are the current causes of failure? Is district model, is this correct approach, and is going to be the recipe for success for future? So this, in 1988, we had this conference in Peshawar, and I invited this gentleman, Mr. Alan John, who was the executive director of Site 7 International, which is a global charity institution based in, it's a legacy of Sir John Wilson. And he came, and in the evening he said, why did you invite me to this meeting? I said, because we want to start a national program, and we see if we could do collaboration. He said, see that we have blacklisted Pakistan. I said, how have you blacklisted it? He said, we've been working for a long time with one small area, Pakistan, and after 10 years we found out that nothing has been done. All our money has gone down the drain. So I said that, well, you are punishing the entire country because one man made a mistake. So he said, okay, I'll say we will work together with you, but what do you want? And he suggested that in India we give money, they hold camps, and then cataracts are done. We pay them per. I said no. I said we want district-based services. He said, have you any evidence? I said yes. He said where is the evidence? I said your country. In your country you have district-based services. Yeah, I worked there for 6 years. So why don't you replicate that? So he said, okay, do you want to do a research and find out that whether it is feasible here or not? I said yes. So we took this mobile unit, put it in front of my department, put a surgeon, a nurse, and an operation theater assistant. So worked for 2 years. The site saver team came and they said, you have done 1,000 plus surgery in this box. So he said, go to a district. So we went to district. And in district, we did everything that is needed, and then we started work. For 2 years we worked, external evaluators came. They said, yes, 2 surgeons were there and they were doing 150 surgeries. And here now 1 surgeon is doing 1,050 surgery. So replicate it. So we went for replication and we went to 10 districts. And these 10 districts were selected on the basis of poorest socioeconomic indicators. Poorest. So we started work in those 10 districts, and what was the results? Now, this is a very interesting, you could see how the uptake of surgery improved with the passage of time. And one thing which in fact surprised everybody, that the women were not coming forward initially. See, the men were exceeding the number. But then in the 5th year, a lot of women started taking the district-based health services. So that was a very, very interesting positive sign. So national task force, we then knew that we are going to be on the right track. So we then appointed national task forces on refractory and low vision, childhood blindness, corneal blindness, trachoma, diabetic retinopathy, research and development, glaucoma, and human resource development. And the salient feature of the program was that it will be developed as a package: infrastructure, human resource development, and management and technology. It will have to be comprehensive, it will be district-based, and it should then lead to a national eye care program. We didn't go to tertiary institution. All our work was primary and secondary level. We needed a commitment, political as well as collaborative commitment. So here is a function in Peshawar where the president of Pakistan is there, the regional director of WHO is there, the Saudi prince is there, and there we made a decision that we are on the right track and we must move on. 2 minutes, okay. So that's what was the district program. It will be planned here, implemented, monitored and evaluated, and with very close contact with the primary health. And that's how it will lead to a national program. Well, at this route, this body was the area for intervention in healthcare, where this area was for health, for research, for tertiary care, referral treatment. Now, what did we achieve? The total number of ophthalmologists from 80, it went to 2,000. We trained 100 community ophthalmologists. We, in fact, we established a new institute in Peshawar, which attracted a lot of international students. In the entire Middle East came there. We even trained Chinese students in that institution for 1 year. And we established a number of allied health institutions in each province. This was the sort of the government structure, and this was the health delivery structure on this side. 2 important institutions came with it. One is the Al Shafa Trust, which is now the apex institution in the country, and the LRBT, which is a charity organization. We run it since 1984. And it has now 32 hospitals. 1/3 of the entire cataract surgery work in the country is done by this, and it's all free of cost. What was the sequence of events? First national survey, then for 5 years, second national survey, and then the first 5-year plan, second year 5-year plan, and then we went for a survey. And a survey which was in fact not conducted by Pakistanis, but in collaboration of the London School of Tropical Medicine and Hygiene. And here is the result, from 1.7% to 0.9%. So the summary of Pakistan's journey from darkness to light was a global vision, genuine professional and political commitment, generous external and internal support, grand partnership, excellent governance. And these are the people from whom who inspired us. These are the people who stood by us most of the time. These are the various international organizations who assisted us. And in 2007, I retired, and we instituted Chef International. And the areas of focus, the goal is, vision is empowering people and improving their lives. And the areas of focus are cross-disability, inclusive education, disaster prevention, inclusive society, and inclusive development. Ladies and gentlemen, thank you very much. Can I just make one last comment? On this collaboration between APPS and Pakistan, I would suggest that your management should think about constituting a task force where people from either side should sit down, think about it, and then come out with projects which are relevant, sustainable, and effective for the country. Thank you.